everyone, and on behalf of Hetero Healthcare, I welcome you all for this webinar. Hetero prides itself for being one of the few pharmaceutical organizations that thrive on a robust research and development program. 21 years of expertise in pharmaceutical, 25 plus state-of-art manufacturing facilities, presence in more than 120 countries, 15,000 plus employees across globe, 200 plus portfolio products in portfolio, largest privately held pharmaceutical company in India. Hetero Research Foundation started as early as year 1995, spearheaded by more than 500 top-notch scientists. Excellence in developing generics, difficult to make and complex APIs, novel drug delivery system, new chemical entities, and biosimilars. Hetero Healthcare is one of the world leaders in developing and manufacturing a wide range of brands in various therapy segments, including gastroenterology and hepatology. More than 3 decades of experience in manufacturing and marketing pharmaceutical. Hetero Healthcare has also been in forefront for providing drugs for COVID-19 pandemic, such as COI for injection, that is remdesivir, and Favir tablets, that is favipiravir. Hetero Gastrocare is committed towards creating awareness about hepatitis B and C, along with products like Heptivite, providing access to high-quality medicines at affordable rates and enriching lives of patients for better well-being. Adding to the portfolio, we are pleased to introduce MidoHep, a brand of midodrine hydrochloride, a vasoconstrictor being widely used in orthostatic hypotension and various secondary hypotensive disorders. It has been recently shown to have a significant improvement in cirrhotic patients with ascites. For further detailed discussion on this topic in our today's webinar, I would like, that is recent advances in the management of refractory ascites and HRS. I would like to introduce our moderators and speaker. Today we have great pleasure in welcoming Dr. Srinivas Nistala sir, who's a speaker, MDDM, DNP Medical Gastro, lead gastroenterologist and hepatologist, HOD Endoscopy Unit, Department of Gastroenterology, Apollo Hospitals, Visakhapatnam, Andhra Pradesh. And today we have moderator Dr. A.V. Sivaprasad sir, MD, PGI, DM Gastro, AIMS Delhi, FSCG, consultant gastroenterologist, Institute of Gastroenterology, Visakhapatnam, Andhra Pradesh. And we have a moderator today for today's evening, Dr. G. Satyanarayana sir, MD, PGI Chandigarh, DM, AIMS Delhi, Associate Clinical Director and Head of Department, Care Hospitals, Visakhapatnam, Andhra Pradesh. So it gives me immense pleasure to share today's discussion, today's webinar on a special day, recent advanced management of HRS and RA. And really welcome you all, three great gurus, what I feel I am quite a long time being blessed by you all with your visits to Visakhapatnam. I would hand over the session to moderator, Dr. Sivaprasad sir, to take it further and for the day's proceedings, sir. Dr. Sivaprasad sir.
Yeah, good evening. Thank you for the opportunity, and welcome my colleagues, Srinivas, who's the speaker, and G. Satyanarayana, who's my co-moderator. The topic is an interesting one. We know that over the course of decades, the management of refractory ascites and HRS has undergone so much evolution, and the approach and treatment has changed from the time, say, when before the time that I was doing my gastroenterology, and during that time and later, every decade you have seen refinements in terms of approach and management and better understanding of the pathophysiology. I think that's made a lot of difference in terms of figuring out how the kidney and the liver are related and what are the implications of liver failure on the kidney function. In these areas, there's so much of incremental knowledge that has come over the course of these decades. And so it's important that we understand what is the best approach today to the management of refractory ascites and HRS, and with newer therapeutic agents also now being available. And for this, we have Srinivas taking us through this. Satya, Satya, would you like to make a few comments?
Yeah, the recent
Got
advances,
some, yeah, okay.
the recent advances in the pathophysiology knowledge about the involvement of kidney and liver had made new therapeutic scopes, new therapeutic interventions to further help us in the management of this disease. So I request Nistila to start the presentation to move forward.
Yeah. Hi. Good evening, everyone. Once again, can you see my slides now?
Not yet. Yes.
Now you can see my
Yeah.
slides, sir.
Yeah, they're fine. Go ahead.
Right. So thank you,
Also mute
Shivaprasad sir, and thank you, Satyanarayana sir, for the introduction. And today's topic is about recent advances in management of refractory ascites and HRS. So in the next 45 minutes or so, I'll try to cover most of the recent advances and the basic pathophysiology and the newer insights in the pathophysiology. So in the initial first 10 slides, I'll tell you about the basic cirrhotic and the natural history of a cirrhosis. And then we'll go to the management of HRS and the refractory ascites. Yeah. So the content will be cirrhosis, management of ascites and HRS. Cirrhosis represents, can I ask one second, how can I make it small? Yeah. So cirrhosis represents a late stage of the progressive hepatic fibrosis characterized by distortion of hepatic architecture and formation of regenerative nodules. It generally considered irreversible. If specific treatments are aimed at the underlying cause very early in the disease, some chance of improvement or even reversal is possible. Etiology, as everyone knows, very common, especially in Indian setup. It is 1/3 is alcoholic, and 1/3 of the causes are chronic hepatitis B and hepatitis C related. Nowadays, NASH related are actually picking up. It is broadly classified as compensated and decompensated. Compensated caused is because of patient has not developed any ascites or any other complications of portal hypertension. Decompensated, patient has developed portal hypertension and symptoms of any of the following, like ascites or arterial bleeding. So this is an important slide. We'll spend some time on this. So if you concentrate on the second and the fourth rows here, so the progression of cirrhosis depends upon the portal hypertension and the severity of the portal hypertension, and also the symptoms. So if you can see in the earlier stage, it is called as mild portal hypertension with HVPG of more than 5 but less than 10. As the portal hypertension increases to more than 10, it is called as clinically significant portal hypertension. It is at this stage that varices start developing here. So no varices when the portal hypertension is mild, and varices start developing when the portal hypertension, that is HVPG, is more than 10. So as the portal pressure increases to more than 10 or 12, higher risk of major events. So the other way of looking at it is initially compensated cirrhosis. There are no varices, mild portal hypertension. And as the clinically significant portal hypertension develops, varices develop. And as the symptoms, as the portal hypertension increases, bleeding episode or non-bleeding decompensation or more than two decompensating evidences occur. And finally, it is late decompensation in the form of refractory ascites and HRS. So in the third row where you can see, the most important circulatory changes occur according to the severity of the disease. So initially there is minimal or absent systemic arterial vascular resistance, and there is normal cardiac output. There is moderately increased, moderately increased vasodilation of the systemic circulation, compensated by increase in
splanchnic circulation.
splanchnic arterial vasodilation, associated with compensated increase in cardiac output. But further increase in vasodilation does not result in increase in cardiac output. And finally, there is severe hemodynamic impairment and decreased organ perfusion. So different stages classification of this. Stage 1 is compensated, no esophageal varix, and the mortality is very less. Stage 4 decompensated with gastrointestinal bleeding, mortality of 57%. So this is one more schematic which shows stage 0 and stage 6. There is mild portal hypertension or no, and less than 10 portal hypertension is present. So as the disease progresses, the patient develops progressively increasing portal hypertension and complications. So coming to the ascites. Ascites itself is described as accumulation of fluid in the peritoneum, most commonly found in cirrhosis with portal hypertension. Depending upon the etiology, it is high sag or low sag. I'll not go into the details of that. And ascites can be associated with SBP, hepatic hydrothorax, and other complications of HRS. Ascites itself and these complications are significant cause of morbidity, and the management of ascites is very complex as the disease progresses. So this ascites formation in a particular patient is an important landmark in the natural history of his disease. So a patient without ascites and a patient with ascites, same patients, completely different disease you are seeing at the patient. So how it develops? No portal hypertension, very mild portal hypertension. There is no ascites, mild vasodilation. Then as the portal hypertension increases, uncomplicated ascites. Then severe vasodilation leads to refractory ascites and then to renal HRS. So what causes this vasodilatation of this splanchnic circulation and also the systemic circulation at a later date is, so whenever, this is a pathophysiological mechanism. So whenever there is obstruction to the portal flow, there is shear stress to the splanchnic vessels. This shear stress leads to increased production of vasodilatory substances like nitric oxide. So increased production of nitric oxide together with decreased degradation in the already diseased liver, so causes increased NO and splanchnic vasodilatation. So this splanchnic vasodilatation and some of these nitric oxide escapes into the systemic circulation via the portosystemic shunts. So splanchnic vasodilatation and the NO in the systemic circulation ultimately cause decreased effective blood volume. So this decreased effective blood volume is the most important mechanism which causes activation of the vasoconstrictor system. So though the patient is having adequate blood volume, but because of the severe splanchnic vasodilatation, also the systemic vasodilatation, effective blood volume is reduced, leading to renal vasoconstrictor system activation, predominantly the RAS and the sympathetic nervous system, and also the non-osmotic arginine vasopressin system. All these three are activated, leading to renal hyperperfusion, hypoperfusion, and water and sodium retention. The other important pathophysiological mechanism, which is now taking more attention, is it is the translocation of the gut microbia into the systemic circulation. So whenever there is portal hypertension, there is leaky mucosal surfaces. The bacterial proteins and the bacteria just enter into the systemic circulation. Then there are pathogen associated molecular proteins. These are very, very important and they cause a systemic inflammation. So this is the second most important pathogenic mechanism nowadays. Initially, it was only thought as to be a vasodilator and vasoconstrictory dysregulation, but associated inflammatory reaction is now seen as a very important pathophysiological mechanism. So splanchnic vasodilatation with systemic inflammation, these are the two important pathogenic mechanisms which are leading to HRS and refractory ascites. So grading of ascites is mild, moderate, and severe depending upon how we are able to check it. Only ultrasound detection if it is less than 500 ml, and moderate is what we see clinically. Severe, it is very obvious to us. So coming to the treatment of ascites, depends upon the cause. Low sag ascites, non-cirrhotic, so we are leaving it. High sag ascites is mostly cirrhotically rated. Alcohol, if it is, you have to stop. Other treatable liver diseases. Portal hypertension is managed with salt restriction and diuretics. And most important is to identify the precipitating factors. Dietary indiscretion, diuretic non-compliant, GA bleeds, HCC, and other NSAIDs to be stopped. This is the general mechanism of treatment for ascites. So I will spend some time on this slide. So what is important is sodium restriction. This is the mainstay of the treatment. Sodium intake should be restricted to less than 5 grams per day. That is 2000 milligrams of sodium or 88 millimoles per day. So this alone will eliminate ascites in less than 10% of the patient. So how to know that the patient is on salt compliant diet or not? So if a patient, if you put him on a 5-gram salt restricted diet, the urinary sodium excretion will be 78 millimoles per liter. So if you do a spot urinary sodium potassium ratio, and if it is more than 1, it shows that the patient is excreting 78 millimoles of sodium per day. So this is very, very important. If sometimes the patient they're not on salt restricted diet or they're not non-compliant, and we keep on increasing the dietary doses. So this itself shows that the patient is not compliant. As the disease progresses and the ascites becomes refractory ascites, this amount of sodium excretion becomes very, very less. Sometimes people excrete less than 10 or 15 millimoles of sodium. So this is a stage where diuretics will not work. So what is the definition of refractory ascites and How do we proceed it? International Ascitic Club, sorry. This is the group which has given the definitions of refractory ascites. Almost every European and American association have this similar guidelines. Ascites that cannot be mobilized or early recurrence of which cannot be satisfactorily prevented by medical therapy. So this is called as refractory ascites. It is again classified into diuretic resistant and intractable. Ascites that cannot be mobilized or the early recurrence of which cannot be prevented because of lack of response to sodium restriction and diuretic treatment. This is diuretic resistant. So even if you're giving diuretic treatment, the patient is not responding. Diuretic intractable is ascites that cannot be mobilized or early recurrence of which cannot be prevented because of diuretic related complication. This is called diuretic intractable. So we'll know what are these things. So that is the definition. The criteria should be treatment duration. Patient must be on intensive diuretic therapy for at least 1 week and on a salt restriction of less than 90 millimoles, that is 5 grams of salt per day. Lack of response is defined as loss of less than 0.8 kilograms over 4 days and urinary sodium output less than sodium intake. Early ascites recurrence is recurrence of grade 2 or 3. As I told you, it is grade 2 means clinically visible ascites within 4 weeks of initial mobilization. And what are the complications of diuretic? Development of hepatic encephalopathy, renal impairment, that is increase in serum creatinine to more than 2 milligram, and hyponatremia, serum sodium less than 125, and hypo or hyperkalemia, potassium less than 3 or more than 6, and incapacitating muscle cramps. So in a patient who classifies into refractory ascites, he has to satisfy all the above criteria. And the maximum doses of spironolactone and furosemide to be given are 400 and 160 milligrams respectively. So how do we manage these patients with refractory ascites? So once again, to start with, it is a medical therapy, then large volume paracentesis, tips, liver transplantations, others, and other palliative therapies. Once again, initial treatment, eliminate all the harmful medications. Any drugs like ACEs, ARBs, and NSAIDs should be stopped. Systemic blood pressure tends to progressively fall in those, and especially when the MAP is more than 80, to have a 70% chance of survival of 2 years, and a MAP of less than 80 have a 20% survival. So whenever the patient is having advanced cirrhosis and refractory ascites, the mean arterial pressure is very, very important in prognosticating thing. And why we need to stop these two drugs are ACEs and ARBs decrease MAP and block the production of compensatory vasoconstrictors. So because of this prognostic value of MAP, it is very, very imperative to stop drugs which decrease the blood pressure. Also, NSAIDs inhibit the synthesis of renal prostaglandins, leading to renal vasoconstriction, a lesser response to diuretics, and possible participation of acute renal failure. So these are the 4-5 drugs which should be immediately stopped in a patient. Low sodium diet and diuretics. Once again, the sodium should be reduced to less than 2000 milligrams. 1 spoon of salt contains 2000 milligrams of sodium or 88 millimoles of sodium. So this is equal to no added salt in the diet. So diet as such contains some sodium, the vegetables and the fruits, whatever we eat, they contain some sodium. So in these kind of patients, there should be no added salt in the menu. Diuretic should be discontinued permanently in patients with diuretic-induced complications. As you know that if it is a refractory or intractable ascites, these complications will develop. In such cases, we should stop them. And diuretic should be continued only when urinary sodium is greater than more than 30 millimoles per day. So this is the importance of finding the urinary excretion of sodium. So if the patient is not at all passing any sodium in the urine, then it is not useful to start or continue on any diuretics. This is the one which we have already discussed. So this is very, very important, how to monitor a patient for sodium complaints and whether the patient is excreting sodium or not. So this spot urinary sodium potassium ratio of more than 1 is very, very important. You don't have to measure the whole 24 hours urinary sodium. Spot sodium potassium ratio is very, very important. Next is discontinue in select patients with refractory ascites. Beta blockers have to be discontinued. So there was a lot of discussion regarding the role of beta blockers, complicating the disease further by increasing the permeability of the intestine to the gut bacteria. So a window hypothesis was initially suggested, so that at the starting of the varices, appearance of grade 2 varus and the appearance of refractory ascites, it is that period only when beta blockers can be used. So, but now the present study shows that beta blockers can be continued unless the patient has complications of hypotension of less than 90 or creatinine of more than 5 and a hyponatremia. So there is little confusion here because there were a lot of studies which have initially showed that beta blockers are helpful, but now they're saying that beta blockers should not be used. But recent analysis and the recent guidelines, which was published in 2020 November in GUT, they say the guidelines suggest that beta blockers can be continued unless the patient has severe hypotensive episodes, surrogate hypotensive episodes in the form of hypotension or a rising serum creatinine. So after doing all these things, next what are the options we have for refractory ascites? Large volume paracentesis, long-term human albumin infusions, tips, vasoconstrictive drugs, and of course, transplant. So LVP is the first line of treatment for refractory ascites and is defined as a direct aspiration of more than 5 liters of ascites. So we'll go to the treatments one by one. And the other two are alpha pump. It's a new technology. We'll discuss it in detail. And liver transplantation, obviously, is the best choice provided the patient has a liver for them. So large volume paracentesis is very effective, especially in patients who is not passing any sodium in their urine. And if the patient does not excrete any sodium, paracentesis to be done every 2 weeks. So considering that this normal sodium value is 130 millimoles, a 10 liter of paracentesis removes 1300 millimoles of sodium. So 5 gram of salt contain 88 millimoles. And the retention is because non-urinary sodium losses are 10 millimoles per day. So 78 millimoles are retained. So if you remove 10 liter of ascitic fluid in a patient, it removes 17 days of retained sodium. So this is how it is effective. So if a patient is not passing sodium at all, that's how the diuresis occurs. So if the patient is not passing sodium at all, and 10 liters of paracentesis removes 17 days of urinary sodium, 17 days of retained sodium. Patient with some urinary excretion of sodium will require paracentesis less frequently. So if no sodium excretion at all in the urine, paracentesis every 2 weeks. If there is excreting some 40 or 50 moles, then you can do it every 3rd or 4th week or so. So this is once again very important. Spot urinary sodium potassium. This is the thing most important. You should all do it in practice. We all do it here. And it is also suggested that albumin to be given after a large volume paracentesis, especially more than 5 liters. So multiple studies have shown that if there is large volume paracentesis, this leads to paracentesis induced circulatory dysfunction, which occurs in the 6th day of paracentesis in the form of increased renin and increased creatinine values. So it has been suggested and advised to give 8 grams per liter of fluid removed. But a lot of studies have come up which have shown that low dose albumin in the tune of 2 to 4 grams of albumin per liter of acidic fluid removed is also equally effective. But the guidelines still stick to this high albumin dose of 8 grams per liter. And there are a lot of debate regarding which is the best plasma expander and all. So multiple trials have shown that albumin is the best plasma expander. And hydroxyethyl, starch, and dextran have their own side effects in the form of allergic reactions and impairing the coagulation profile. So albumin can be infused during or shortly after the paracentesis. And one thing to be remembered is if you reduce the salt intake drastically, it has been shown that this results in reduction in calorie intake also. So 20% of the patient, they have a calorie reduction because of hyponatremic diet. So it is also important to take care of the calorie requirement in such patients who are requiring low sodium diet. And what are the ideal sites for tapping once again? So it should be 5 centimeter above the pubic symphysis and 8 centimeter away from the, you draw a line in the midline and it should be 8 centimeters away from the midline and 5 centimeters above the pubic symphysis. And preferably on the left side because the volume and the depth of acidic fluid is more on the left side because of the paracolic gutters and other places. So it has been proved ultrasonographically the abdominal wall is relatively thinner on this side and the depth of ascites is more. So coming to the other thing is what is the role of long-term human albumin solution? A patient who has undergone ascitic tapping, LVP, and you have given him albumin during the large volume paracentesis. So is there a role of giving him human albumin at home or on a OPD basis? So the multiple studies which have come up, the first answer comes from the answer study. They have done a study, but it is not a randomized study. It is not a randomized control study. The patients were either randomly assigned to either albumin or standard medical therapy. So what they found out is that overall 18-month survival was significantly higher in patients with standard medical therapy plus human albumin, and a 38% reduction in the mortality hazard ratio. So this is an important study which shows that daily or weekly twice albumin injections on an outpatient basis with or without large volume paracentesis, they have resulted in an improved survival. So this study was once again, another study was done. This was done in published in Gut 2000 October. It is a 186 patients were included in it. It's a double-blind placebo-controlled study, and especially this was done in patients who are waiting for liver transplantation. This study did not show any survival advantage. So what they have seen is that they have taken patients who are in end-stage liver disease waiting for liver transplantation. It's a randomized placebo-controlled trial. They're given midodrine plus albumin and placebo only. So what they found out is that there is no change in the development of complications, but they found out that the plasma renin activity and the aldosterone activity has come down, but they didn't translate into clinical benefits. So this is a completely contradictory result to the answer study. So then further analysis of this study, it was seen that most of the patients did not get albumin for a longer duration of time. Majority of the patients only got it for, especially midodrine and a combination of albumin, they got it for only 80 days rather than more than 1.5 or 2 years in the previous study. Secondly, most of the patients undergone a liver transplantation before they could complete the dose of albumin and midodrine. So this study is little, though it is a randomized control study, but the analysis was not done in a proper way. So now a recent study published in Liver International, in this 45 patients were non-randomly once again assigned to long-term administration of albumin, and they have seen that cumulative incidence of 24-month mortality was significantly lower in these patients who are receiving albumin than standard of care, and the period-free emergent hospitalization was also significantly longer. So these three studies have shown that a patient who is undergoing large volume paracentesis, it should be put on long-term albumin as an outpatient basis also. That will decrease the mortality and also need for emergent hospitalizations. So the next important measure is a TIPS shunt. Everybody knows this, highly effective treatment, complete resolution 70% of the cases. But in practical, it is very, very difficult to find a patient who can undergo a TIPS in a real-time situation or in real-life studies. So there is no effect of survival in one study, reduced in other. The most important side effect of TIPS is hepatic encephalopathy, which occurs in up to 25% of the patient, especially if it is in advanced child C cirrhosis, and also if it is an older age group and a history of hepatic encephalopathy in the past. And this is once again operator dependent. You need to have a skilled interventional radiologist to get this TIPS done. So this is the drawback of TIPS, but if the patient is otherwise stable, TIPS is one of the important methods which can be used to reduce the hepatic refractory ascites, and also it helps in resolving hepatic hydrothorax, which is also very, very important. And the indication contraindication depends upon the MELD score, and MELD was initially developed to find out the survival after TIPS insertion. The other new things which have come up is automated low flow pump system called the alpha pumps. So the principle is that they have put a pump in the abdominal area with two pipes in it. One pipe is in the, or one catheter is in the ascitic fluid peritoneal cavity. The pump sucks the ascitic fluid and then pushes back it into the urinary bladder. It is like a continuous slow large volume peritoneal large volume paracentesis. So every 1 hour or 1.5 hour or 30 minutes, 50 to 100 ml of fluid is sucked in, and then it is excreted in the urine. So this looks very, very promising, but we'll see what happens to this. For the first time, this study was published in 2013. 49 patients at 9 centers, followed up for 6 months. Pump was very, very helpful in removing ascites in 90% of the patients, and it reduced the number of large volume paracentesis. About 1/3 of the pump systems had to be explanted. So this is an important side effect of this particular thing. 1/3 had to be explanted because of infections or catheter dislodgement. And during this study, 8 patients died, 3 due to sepsis and 2 due to progressive liver disease. So though it looks very, very promising, but the side effects of infection and other technical issues of the pump. So this study was not showing a very good result here. So then in a multicentral RCT, the alpha pump significantly reduced the need for paracentesis and was associated with significant improved chronic liver disease questionnaire, nutritional parameters, everything. But what they have seen is that meta-analysis of the data from RCT in several case series show 60% did not require LVP following pump insertion. Though this looks promising, there are 30% chances of acute kidney injury, 27% chance of bacterial peritonitis, and 20% chance of urinary tract infection. As of now, not available in India, but this is a promising method which can be used, especially in you are able to see the patient regularly. So NICE recommends that the alpha pump should be used only when special arrangements for clinical governance, consent, and audit or research are available. So this looks very promising in future. Maybe once it comes to India, we'll have to see and we'll have to discuss about this in future. So what are the other treatment other than LVP, TIPS, and alpha pump? So the second line methods after the drugs which can be used other than these are midodrine is especially found to have useful effects, especially patients who are having a lot of hypotension here. So what is midodrine? An alpha-1 agonist acting directly on the peripheral alpha receptors, widely used in other orthostatic hypotensive and secondary hypertensive disorders. A single dose administration of midodrine leads to significant improvement in systemic and renal hemodynamics. The beneficial effects of midodrine have been attributed to modulating effects on autonomic function and peripheral blood resistance. It also found to decrease nitrate and nitrate activity, which is the most important pathophysiological mechanism in refractory ascites. So how it acts? Midodrine, it gets converted to desglycyrrhodine. It's a very strong, potent alpha-1 agonist. Increase in vascular tone and elevation in blood pressure leads to splanchnic vasoconstriction, improved systemic circulation, improved renal function, increased in sodium water excretion, and improving ascites. So this is how it kind of acts. So basic pharmacology, it is converted to a metabolite called desglycyrrhodine, and the half-life of this is around 3 hours. The bioavailability is 93%. It is not affected by food. It is midodrine is not eliminated in the kidneys, but this the metabolite is 80% eliminated through the kidneys in the form of active renal secretion. So what does it do? It increases MAP. It decreases cardiac output, which was increased because of decreased MAP. Systemic vascular resistance is increased, urinary output sodium is increased, plasma renal activity is decreased, and it doesn't cause any significant renal or hepatic dysfunctions. So how do we use it? It is started as 5 milligram orally 3 times a day, and dose to be increased 2.5 milligram per each dose every 24 hours. Maximum of 17.5 grams can be given, or if the MAP is more than 80 millimeters of mercury, we can stop it. And it can be used in patients with hypotension, diabetic resistant ascites, and who do not respond to standard therapies. It should be taken during the day only, because if you're taking very late in the evening, it can cause supine hypotension. The first study on midodrine and its use and its effects on renal hemodynamic renal function was done way back in 1998, where it was shown that even after 3 hours and after 6 hours, this resulted in increase in MAP and increasing systemic vascular resistance. So there was evidence of midodrine working in patients with cirrhosis since 1998, but it was not very not used very clinically very often at that time. So the study done by from India, Virender Singh in PGH Chandigarh, they have shown for the first time, I think they have shown a very good data on a pilot study. So what are the long-term effects of midodrine on systemic hemodynamics, renal function, and control of ascites, especially in patients with refractory and recurrent ascites? They have taken 40 patients and they studied them for full 1 year. So this is very, very important. This is important. You have to give them for a longer duration. So they were divided into 2 groups. 20 got midodrine plus SMT and 20 got only SMT. And all the other standard medical therapy of low salt diet and everything was same for both of the patients. So what they have seen is that midodrine plus SMT was significantly in control of ascites. The combination of midodrine has led to superior control of ascites at 3 months, and mortality rate was also better in patients who are given this midodrine. And they also led to other parameters like increased urinary volume, increased urinary sodium excretion, MAP has increased, and decrease in plasma renal activity. So this not only resulted in clinical improvement, but also midodrine was helpful in correcting the pathophysiological mechanisms which are responsible for refractory ascites and HRS. There was also significant decrease in cardiac output and increase in systemic vascular resistance. So it has been shown that midodrine plus SMT was significantly superior to SMT alone in the control of ascites. So number of clinical papers have come up This study was published in 2014. Midodrine in non-istomic patients, they have found a significant reduction in body weight and abdominal girth after 2 weeks of midodrine itself. And there was a meta-analysis, and systematic review and meta-analysis done. It included 462 patients of 10 trials. So what these people have shown is that they reduced plasma renin activity. This study has shown that the response rate to ascites mobilization was more among midodrine group, but this study did not give any survival benefit compared to other previous studies. Though the biochemical and other physiological parameters showed an improvement, but this study did not give any survival benefit to these patients. Statistically significant effect of midodrine on improvement of response rate and reduced PRA compared to placebo was less costly and more convenient administered drug may be considered a patient with severe cirrhotic ascites. So similar studies were published in 2017 also. Usefulness of adding midodrine besides standard medical treatment patient with cirrhosis and refractory ascites. Group A, Group B. Group B got only Group A got SMT and Group B has SMT plus midodrine 15 mg per day. And they have concluded that it reduces the body weight, increases MAP and 24-hour urinary volume, but none of them has shown survival benefit when used alone or in combination with standard therapy. Is safe treatment for patients with liver cirrhosis in addition to SMT and a better control of ascites, except the study done by Virender Singh, which has shown survival benefit. So this is one such study there. So there are studies with rifaximin and midodrine, which have found that there is improved clinical outcome in refractory ascites. Weight and mean arterial pressure in the study and control group is better with the midodrine and rifaximin combination than alone. And there is survival benefit in this particular study. Conclusion, rifaximin and midodrine added to diuretics in difficult to treat ascites improve systemic and renal hemodynamics and short-term survival and should be included in the management of these patients. So the number of studies which have shown that adding midodrine increases the response to ascites, and there are few studies which have shown that it increases survival benefit also. So there is this one study which has compared oral midodrine versus albumin infusion, 75 patients with cirrhosis and refractory ascites. So they have given midodrine in 2 different doses, that is one given for 2 days and other given for 30 days only. So all these studies, what they have shown, the thing to understand is midodrine to be given for a longer duration of treatment rather than for a short duration. So in this study, what they found is there is a significant increase in 24-hour urinary sodium excretion in midodrine in 30-day group. Renal perfusion improved significantly with midodrine intake for 30 days only. The cost of midodrine is obviously very low compared to the albumin. So this is one study which shows that if given for a longer duration of therapy, urinary sodium secretion increases and perfusion also significantly increases. So takeaway point from this is midodrine is a potent peripheral acting alpha-adrenergic receptor agonist, increases effective arterial blood volume by splanchnic vasoconstriction. It can be added to diuretics to elevate blood pressure. Midodrine alone or alone with octreotide and albumin shown to enable better control of ascites. Oral midodrine is 7.5 grams 3 times. It has been reported to prolong patient survival. There are 2-3 studies which have shown survival benefit. Rest all have shown only response to ascites. And guidelines, American Association of Liver Disease guidelines also suggest that this can be used before subjecting a patient to TIPS or recurrent large volume paracentesis. So this concludes the first half of my talk. The second half is hepatorenal syndrome. Hepatorenal syndrome was thought to be a purely functional type of renal failure associated with hemodynamic changes. Shivprasad sir, hope I'm audible and everything is okay there.
Yes, please continue. It's going well.
Thank you. So HRS was thought to be a purely functional type of renal failure associated with hemodynamic changes, but it is not purely functional entity. This is a new thing in hepatorenal syndrome. So initially during our college days or during ADM, it was taught that patient with HRS, those kidneys can be transplanted with completely normal function in a new patient or any person requiring liver transplant. So now it is known that HRS is not just a functional disease. There are some structural and also some systemic inflammatory responses which are responsible for the kidney disease. Systemic inflammation, oxidative stress, and bile salt related tubular damage may contribute significantly to its development. HRS has a structural component that would not only make traditional diagnostic criteria less reliable, and this also explains the lack of response to pharmacological therapy like vasoconstrictors plus albumin. So it is no more just a functional entity, it is a structural damage and also inflammatory damage to the kidneys are also occurring. So this was the traditional diagnostic criteria which was used initially. Cirrhosis with ascites, serum creatinine more than 1.5. For type 1 or acute HRS, there has to be a doubling of serum creatinine to a final value of more than 2.5 in less than 2 weeks. And all other things, no improvement in serum creatinine concentration after 2 days of diuretic. So these are all the other associated criteria, but this is this was the default definition. So should be more than 2.5 in less than 2 weeks. So with the advent of effective vasoconstrictor therapy for HRS1, clinicians have been concerned that a delay in initiating therapy for more than 2 weeks or until creatinine reaches 2.5 may result in reduced response rates. So what happened is, so there was a change in the classification of acute kidney injury by the nephrologist. By the kidney disease improved global outcomes. So this group has changed the definition of acute kidney injury in general, and IAC guidelines, International Aesthetic Club, have also adapted those same guidelines for acute kidney injury even in cirrhotics. So let's understand the definition of acute kidney injury. So baseline creatinine is stable creatinine concentration for less than 3 months. If that is not available, whichever is the latest creatinine value is available, you should take it as a baseline value. So defining AKI, serum creatinine concentration increases to more than 0.3 milligram per deciliter in 48 hours. So that was in 2 weeks. So there was a long gap before we can make HRS1 diagnosis. But AKI has made it, definition of AKI made it to less than 2 days, or 50% increase from the baseline. So there is the percent and there is an absolute value. And again, it is further divided to stage 1, 2, and 3, depending upon the rise. If it is more than 1.5 to 2 times, if it is more than 2 to 3 times, and if it is more than 3 times. So this is again stage 1, stage 2, and stage 3. Then there is progression of AKI to higher stages, that is from 1 to 2 and 2 to 3. Regression to lower stage. And response to treatment is no response, no regression of AKI, partial regression, and complete regression. So this is the definition of AKI used for non-cirrhotic patients. The same AKI definition has been adopted even by the IAC club. So with this, the new classification of HRS subtypes have come up. So initially the old one was HRS1. It has been newly classified into HRS AKI. Same criteria, absolute increase to more than 3 gram within 48 hours, urinary output. So one more criteria is given is urinary output less than 0.5 ml and percent increase to more than 50% of the baseline value within the 3 months. HRS2 now called as HRS-N AKI, that is non-AKI, again divided into 2 types, HRS-AKD, that is HRS acute kidney disease, and HRS-CKD. So the definition are based on the estimated GFR. So if it is less than 60 mils per minute, or if it is less than 60 mils per minute, if it is less than 3 months, it is called as AKD, and if it is more than 3 months, it is called as CKD. So depending upon the estimated GFR and the values, if it is less than 3 months, it is called as AKD. So with this new classification, how the definition and the criteria of HRS have done is, new diagnostic criteria for HRS AKI, which is initially or previously called as HRS1. So diagnostic criteria is cirrhosis with ascites, acute liver failure or ACLF, increase in serum creatinine to more than 3 mg/% within 48 hours or more than 50% from the baseline. No full or partial response according to AC consent after at least 2 days of diuretic withdrawal and volume expansion with albumin. The recommended dose is 1 gram per kg body weight. Absence of shock. So all other criteria stay except the definition of rise in creatinine. So they have adapted the AKI definition. So no concurrent or recent treatment with nephrotoxic drugs. Absence of parenchymal diseases indicated by this, but this is little difficult because now there are indications to show that there is parenchymal injury. There is also structural injury in patients with AKI. But if you are looking at a very strict definition, so you don't want any of the structural injuries in the form of proteinuria, microhematuria, or urinary injury biomarkers and abnormal renal ultrasound. So this is the definition for AKI. Absolute increase in serum creatinine more than 3 gram within 48 hours. So this is the time of presentation. So from here, if the patient is having more than 3 gram per 0.3 gram% increase in creatinine, or more than 50% in the last 7 days. So this is defined as AKI, and for HRS AKD, so this is and HRS CKD. So if it is more than 3 months and less than 60 mil per hour, it is HRS CKD. And if it is less than 3 months, it is HRS AKD. So this is a schematic to understand the definitions of HRS AKI and HRS NAKI. So HRS2 is now classified as HRS NAKI. So the other thing is real challenge is to differentiate between HRS AKI and ATN AKI. So always it was very challenging even earlier also. So urinary biomarkers like interleukin 18, kidney injury molecule 1, and liver type fatty acid binding protein and neutrophil gelatinous associated lipocalin. So NGAL is one which have been in use for almost maybe a decade or 5 to 7 years now. So this is one thing which is very, very prominent of all the 5 or 6 markers. All are raised in patients with ATN than those in without ATN. So if there's a direct tubular injury, all the 4-5 markers are increased. But most studied is NGAL, and a cutoff of 220 microgram per gram of creatinine in urine is the most specific. So if it is more than 220, it is most likely a ATN related AKI, and if it is less than that, it is. So there are studies which shown that most patients with ATN AKI have values of urinary GAL above this 220 cutoff value, and patients with HRS AKI or pre-renal AKI, 80 and 93% have values below it. So this is very, very promising marker, but not available commercially as of now. So, but this one thing, if it is clinically available, this can be very, very helpful in differentiating between these two things. The second way of differentiating between acute tubular necrosis related and HRS AKI is the fractional excretion of sodium. So this is also we have been reading for a long time. So the thing is, if there is tubular dysfunction, the urinary sodium loss will be more than 2 to 3%. If there is pre-renal azotemia and renal hypoperfusion, the urinary sodium loss will be less than 1%. But in most patients with advanced cirrhosis, refractory ascites, and HRS, there is severe vasoconstriction. So this new cutoff is taken as 0.2%. So if a patient, several studies of HRS, fractional excretion of sodium patient diagnosed with HRS, it was around 0.2%. If this new cutoff is taken, then we can differentiate HRS from ATN, especially the pre-renal type of azotemia here. Pathophysiology, everything starts in the liver, the portal hypertension, splanchnic vasodilatation, decreasing circulating volume, renal vessels, there is RAS activation, renal vasodilatation is reduced, renal vasoconstriction is more, and vasopressin is released simultaneously. Sympathetic nervous system is also getting activated. Cardiac dysfunction in the form of reduced cardiac output, ultimately leading to increased sodium retention and the decreased capacity to excrete solute-free water and decreased GFR. So this is the standard. And now there is a new mechanism of increased pathophysiology in the form of increased inflammation because of injury to the endothelium of the intestinal endothelium and increasing bacterial translocation, all these things. And in this slide, I'm not having it here, but this is one thing. Inflammation has taken over as an important part, and structural damage is seen in patients with HRS AKI. So multifactorial, not just renal hypoperfusion or anything. There is direct tubular damage, there is renal hypoperfusion, there is inflammation, and there is also microvascular dysfunction. So multifactorial now, it is not simple vasodilatation and renal vasoconstriction. So what are the treatment options we have now? General measures, pharmacological, non-pharmacological, and preventive. So general measures are patients with type 1 HRS usually require hospitalization. Type 2 can still be managed at home. More than 5 liters fluid will be removed, and albumin seems to be superior in preventing that paracensis-induced circulatory dysfunction. And so this is very, very important. And the other measures which we are having for these are discontinue diuretics to start with once you have this. So beta blockers and potential nephrotoxic drugs to be continued to stop. Reduce the dose of lactulose if diarrhea is excessive. Patients who have actually lost blood, they require blood transfusion. Septic workup is mandatory, and empirical antibiotic therapy has to be given. So what are the drugs which can be used? Renal vasodilators, not to be used at all, like dopamine and other drugs. So what can be used are vasoconstrictors. Most important is terlipressin. The other one is octreotide, then midodrine once again. Systemic vasoconstriction are the most prominent pharmacological agents in the management of HRS. So this is very, very important. We should do a vasoconstriction both systemically and also at the renal level. So what are the different systemic vasoconstriction? What combination therapies have been used? So we'll briefly go through those slides here. So in United States, terlipressin is not available. So some data on terlipressin is mainly from the European and other Indian studies. And in United States is mostly octreotide with or without albumin and midodrine. So octreotide with albumin infusion ineffective. This has been proved in multiple studies. Oral midodrine monotherapy slightly improved hemodynamics, but did not improve the overall survival or improve the renal function. Midodrine plus octreotide and albumin. This is the only combination available in United States. So they use this combination only. But multiple studies have shown that, I'll show subsequently, that this is not a very good combination since they don't have any other option. They're using this particular study. So how to treat and evaluate the response? Terlipressin albumin is number one, followed by NORAD and albumin. Third is octreotide, midodrine, and albumin. This is the combination which is as of now not very preferred. So terlipressin albumin, you give, it has three options, either a complete response, partial response, or a no response. How terlipressin acts? Binds to V1 receptors of this vascular smooth muscles, causes vasoconstriction, both systemic and splanchnic. Dilate the intrahepatic vessels, reducing the hepatic resistance to portal flow. Ultimately, reduction in portal pressure is seen. So increase the mean arterial pressure by more than 5 millimeters mercury on day 3, and serum bilirubin of less than 10. These are the good predictors of response. Serum creatinine is a very important predictor, and a patient with high baseline creatinine are very unlikely to respond. Use of terlipressin associated with the risk of ischemic effects, especially in 15 to 20% of patients. Patient with ischemic heart disease should be very careful when you are giving it. So if the MAP is increased by more than 5, and if there is a decrease in serum creatinine and serum bilirubin less than 10, Child-Pugh score less than 30, these are all good predictors of MAP, and the treatment should be continued for 5 to 14 days at least. The second drug which is used is norepinephrine. Norepinephrine versus terlipressin HRS1. It was found to be as efficacious as terlipressin in the reversal of HRS without significantly increasing the adverse event. The only problem with norepinephrine is it has to be given in a central line. It has to be given in a central line, unlike a terlipressin, which can be given in peripheral line. So there are small studies which have shown that even norepinephrine infusion itself is very useful, but the data is more favoring terlipressin with albumin infusions. So it is not usually given alone, it is given in combination with octreotide. So there is a study which has shown 162 patients of HRS, 70% patient received midodrine octreotide albumin, and it was compared to cohort who did not receive any therapy. But there are multiple RCTs done and a meta-analysis done which shows that RCT comparing octreotide and NA and terlipressin and HAS. So there is an RCT which compared octreotide and noradrenaline with terlipressin and HAS. So they have shown that terlipressin with human albumin solution is more effective than any other combination as of now which we have. So all the guidelines, they talk about giving terlipressin with albumin infusion for 5 to 15 days. And the other recommendation is not to go for hemodialysis initially, because most of the patients, they don't tolerate hemodialysis well because of the low mean arterial blood pressures. So it is best avoided unless the patient is being taken for a transplant in the immediate few days. So what are the recommended doses of vasoconstrictors and this? So terlipressin can be both given as a bolus and an infusion. Bolus, it can be quickly delivered, but the chance of side effects in the form of diarrhea are more. So it can be given as 0.5 milligram intravenous every 4 to 6 hours, then increased to 1 to 2 milligram every 4 to 6 hours, maximum up to 14 days. And continuous infusion 2 milligram per day, then you can keep on increasing up to 4 milligram per day, maximum of 12 milligram per day. Norepinephrine 0.5 to 3 milligram continuously achieve a mean arterial pressure, increase in the mean arterial pressure of 10 milligram. Midodrine combination, it is not very preferred for HRS when compared to refractory ascites. Midodrine is 7.5 milligram 3 times a day, maximum up to 30 milligrams can be given. Octreotide both as a combination subcutaneously 3 times a day. So these are the different combinations how we use it, but the most preferred combination once again is terlipressin plus albumin here. I think I'm coming to this here. So renal dysfunction, this is the flowchart for diagnosing and treatment. The renal dysfunction, volume extension, and albumin. Look at the treatment response. If there is no response, add a vasoconstrictor if KHRS criteria are met. Response to treatment, you continue giving for 14 days. Even after 14 days of response, the patient initially responds, and in 20% of the patients, they again develop HRS. So again, you can treat them with the same combination in such kind of patients. But if the patient is not responding, you should be sent for a liver transplant, actually. So summarizing, development of ascites is an important landmark in a patient with cirrhosis. So if you see a patient for 4-5 years and the patient without cirrhosis is completely different pathophysiology wise and also disease wise the moment he develops ascites. So that is the most important first precipitating event in most of the patients. And it is the most common decompensating event and occurs 5 to 7% cases per year. So if 100 of the 100 patients, you are seeing 70 will develop ascites in the next 7 to 10 years. As the severity of cirrhosis increases, ascites become refractory to simple medical therapies. Maximum dose of diuretics should be attempted before going for other therapies. Large volume paracentesis, long duration of HAS infusion tips are the mainstay of therapy in these kind of patients. Midodrine with or without HAS is also very useful in giving LVP free survival to these kind of patients. So this is something I take away from today's talk. LVP and long-term albumin is being long-term albumin has picked up in the recent times. LVP was the standard of care, and long-term albumin with midodrine. These are the two things which we should be doing now. And LT is definitely the therapeutic option. HRS is not a purely functional renal failure. Inflammation, structural damage play an important role in pathophysiology. Newer definitions and criteria are important to note. So the criteria of HRS have changed to HRS AKI and NAKI. Precipitating events and drugs to be meticulously identified and removed. Urinary markers like NGAL, when available in clinical settings, will definitely help in differentiating these two different ATN and AKI. Terlipressin and albumin infusions are the mainstay of treatment in these patients. Patients with lower serum creatinine before liver transplant have a better survival and less chance of developing CKD post-transplant. So why it is important to correct even if the patient is going for liver transplant? Because if the albumin is high pre-transplant, so the chance of patient having a impaired liver function or a kidney getting going into CKD is very, very high. So it's always useful to reduce the serum creatinine below. Norad and midodrine are less useful compared to terlipressin and albumin in the setting of HRS, but in case of refractory ascites, it has a very important role to play. I think that's my last slide. Thank you for the patient hearing, everyone.
Yeah, thank you, Srinivas. I think that was excellent, a really wide-ranging and comprehensive coverage, and I think especially with highlighting the recent developments in this field, which are really interesting and challenging. There are a number of questions that have come up in the chat box. We'll just address those first, and then you can, there are further comments to be made. We'll go along. So Dr. Venkateswarlu asks, what about the combination of midodrine and beta blockers? What happens if we prescribe them together? Are there going to be interactions in terms of counteracting effects on the blood pressure and the systemic circulation? So what is your opinion as far as the patient is on? Should you stop beta blockers, or is it anyway midodrine is usually given when beta blockers are stopped? What's your comment?
So we don't have to stop beta blockers just for giving midodrine. Beta blockers, as such, as I told, there was a controversy which has happened. Initially, they told that beta blockers are useful. Then they have told that in refractory ascites, beta blockers are not useful. But the latest recommendation, they don't tell to stop beta blockers for want of hypotension, unless the patient is going into severe hypotension of less than 90 or a rising creatinine levels. But you can easily give beta blockers and a combination of midodrine. They're not contraindicated at all. You can reduce the dose of beta blockers, or you can change to other selective beta blockers like carvedilol if you want to definitely go for a prophylaxis of varices.
I think carvedilol will be associated with more hypotensive effects, so that may not be the answer. But the point is, if the BP is stable, and then obviously you don't need to stop the beta blockers. I think that's the message that we need to convey. That, and if the patient is in the clinical situation where there's refractory ascites and already having a compromised, mean arterial pressure, then it will be better to stop beta blockers.
Stop both the blockers, right?
And then you give this one. Do we have any idea how many patients undergo TIPS in India? Is there any kind of census or audit that are available approximately? I think the numbers are very small, really speaking. I mean, maybe does anybody, Satya, you, Srinivas, roughly?
I really don't know the numbers, sir, but I don't think the patients are those who are having refractory ascites. So already they are in child C status. So if they are in child C status, going to TIPS will lead to increased risk of hepatic encephalopathy and complications.
So I think the common indication in India for TIPS is as a rescue TIPS for bleeding rather than for refractory.
Rather than refractory ascites. Yeah. But I would estimate it's probably in single digits of maybe 10, 20 patients per year would be probably undergoing TIPS. I don't think much more than that is reported. Most centers find it very difficult to find the right patient for TIPS. even for rescue bleeding because they're so critically unstable, or even for refractory ascites because of, you have to fulfill all the criteria.
And depends upon the availability of the radiologist also.
Yeah, so many factors.
Yeah,
the logistics also are phenomenal. Cost is involved.
Cost is phenomenal.
Phenomenal, yeah. Another question is, midodrine does not cause the blood-brain barrier. So what are the risks of, side effects associated with midodrine? What are the side effects associated with administration of midodrine?
So no major or significant renal or hepatic side effects have been described, sir.
Okay.
But some people have marked rise in their blood pressure, so we have to watch.
We need to titrate, sir. We usually recommend is 5 milligram TID, but we start at 2.5 TID, ask them to come back in a week or 10 days to see how the patient is. Then we increase it to, on OPD basis, I discharge the patient on 2.5 milligram to start with, or then titrate it.
Yeah, I think that's an important message, that unless you're able to follow up closely the blood pressure of the patient and titrate the dose accordingly, you should not just start with midodrine.
Right, sir. Right.
We start beta blockers. We start beta blockers blindly, fill it, shut it, forget it types, and then patient comes back, we check the BP, but we know that most of the time patients tolerate the beta blocker dose that we give quite well, but midodrine, we should be sure that
little careful,
that we can follow
for increasing. Yes.
Yeah. There's a question from Dr. Sagar. Along with, if you combine rifaximin with midodrine, what is the additional survival benefit in patients?
So as I showed one study, sir. Yeah, there is a very small study. We showed that combination of these two in a patient with refractory ascites. But I think further data is required. Most of the patients are on rifaximin for primary or secondary prophylaxis of hepatic encephalopathy. So I think a larger study or a proper study should be done to know what exactly is happening. There is one study which has shown survival benefit there.
So,
but I think Sagar is in, he himself is in a transplant center, I suppose. Sagar, yeah. Yes, so I think Sagar, you can also get back to us with the further data on this.
And Dr. Sunita asks, what's the difference between recurrent ascites and refractory ascites?
Refractory ascites by definition is recurrent ascites which we cannot mobilize, and it is again divided into two types. So to call it refractory, it has to be recurrent.
Yes, I think that's simple. And in refractory, there are patients whom, and which really is not a clinically important group. I don't think there's anybody in India who has taken 160 mg of furosemide and 400 mg of spironolactone.
Really, sir, after twice a daily dose, they develop hyponatremia or cramps or HE.
The maximum even I have used is probably four tablets a day is really the maximum that even I have tried. Beyond that, really, there's no clinical experience with 160 and 400. So most of patients are diuretic intractable.
Intractable.
Tolerate diuretics after a certain dose. It may be 2 to 4 tablets of laclactone combination. Dr. Prabhakar Garg asks, how do we do this titration of BP? We mentioned that you have to monitor BP and titrate it, but then what's your schedule for?
So more than 20 millimeters. Okay, how do we do? So initially, we in the last 3-4 months we have been using it more frequently, sir. So 2.5 milligram 3 times a day. We discharge the patient, but discharge they are usually 90/60, 100/60. They come back after a week. We see how he is responding. He's already on diuretics. So after the first week, we call him again after 2 weeks. So initially first 1 week and again after 2 weeks. Then we make it 5 milligrams 3 times a day. So if the patient is stable at this dose, we don't increase it further also.
Okay, so most doses are
15 milligrams. That's the thing.
15 mg per day.
15 mg per day. Yes.
And is there a range at which, what is the point at which you would bring down the dose? What would be the BP at level?
Actually, I never had to bring down the dose till now. It is patients are doing 110, 120 millimeters mercury SBP, and they are adequately controlled with the ascites part. So I don't further increase it. But I never had to bring down the dose till now.
That would only be when you keep on escalating to 10 and other higher doses which are there in the literature. But I think in practice,
15 milligram is the max I think we are using. I mean, other people they can.
The side effects of midodrine you already mentioned. Then there's what is the concept of adding rifaximin to midodrine? Maybe you can highlight.
So the thing is, nowadays, not only just the vascular compromise or hemodynamic instability, but there's a lot of inflammatory activity which has been found to be responsible for both HRS and refractory ascites. Maybe it's acting as a gut decontaminant.
Yeah, so that's important, that the whatever bacterial translocation or even bacterial product translocation is occurring. By giving rifaximin, you're modulating that significantly. So rifaximin brings down portal pressure, rifaximin improves all these inflammatory parameters, etc. There is a wide range of benefits with.
So because these, I didn't tell the detail of that inflammatory parameter. Most of the inflammatory parameters are indirectly against stimulating nitric oxide production.
Yeah.
So after the inflammation, they in turn increase the nitric oxide production, which is causing refractory ascites again.
Yeah, I think those are the questions available. No, one. Yeah, that's it. Satya, would you like to make some observations, comments, anything, your own experience or anything?
So only thing is that when we are using midodrine, we have to be very cautiously monitoring the pressures. Some people come with severe hypertension and headache, those kind of features. So we have to be very watchful and regarding that, and we have to also educate the patient regarding
Yes,
this possible side effects, which they have to keep watch and report immediately. Other than that, Srinivas, your presentation was excellent with lot of
2.5, sir,
information.
the recommended was, thank you, sir. Sorry. Thank you, sir. 2.5 milligram was the recommended starting dose, 5 milligram TAD. But since, as you told, follow-up is difficult and things, so we started half the dose 3 times a day to see how things are proceeding. If the patient is coming back to you, is not getting lost to you, then you can make it 5 milligram 3 times a day.
Absolutely.
Yeah, I think that's a very cautious and safe strategy for most patients. Once you do that kind of low dose and just bring it up after observation, the chances of really BP going up to high levels would be quite low. You would accept that, yes, this is the plateau dose that I'll be satisfied with. Yeah. So any other one thing I'd like to make is that practically we have to understand that the situation in which we give a drug like midodrine ultimately is from the patient's point of view a very small window between unless that he's going for transplantation. If you see the control studies, the control patients in the studies, the survival was less than 6 months. I mean, it's not mean survival. The overall survival was less than almost all patients died within 6 months. So literally, you're looking at a situation where unless the 6 month patient is not expected to survive 6 months, that's where you're adding in midodrine and trying to prolong prolong life for some time. But without a transplant, you're just buying some time. You're really not solving any of the problems. So if somebody has a 6 month survival, he has basically already more than fulfilled the criteria to get transplanted. So in that situation, you're saying that, okay, you don't have a transplant available. Maybe you can buy some time, improve his clinical performance status with midodrine and see maybe whether you can transplant him down the line. But without a transplant available, this kind of window that the patient has.
But 2 studies, sir, this Virendra Singh study, they have given the drug for almost a year, sir.
Yes.
So that is where, maybe patients who are not very sick also, you can start little earlier. Not wait for the late stage, the patient going into HRS where nothing works kind of thing. He has to be admitted for albumin and terlipressin. And one more study, sir, the March study, which showed that midodrine plus albumin doesn't have any survival benefit. The second study after the answer one. So the editorial was written by, the comment to the editor was written by Virendra Singh, where he told that the maximum patients received midodrine for only for 80 days. Number 2, what he told is that majority of the patient got transplanted before the 90-day period.
Yeah, they already fulfilled the criteria.
Yeah, so they were not able to study the effect of midodrine and they concluded that this is not very effective.
Absolutely.
That's what he was telling. So a lot of things have changed, but these people have not gone to the details of this. That's what Virendra Singh has written.
There's some recent information about sodium restriction, whether we can be a little more liberal in patients who are not in refractory ascites. Let me be clear. Once the patient has reached a stage of refractory ascites, as you very well highlighted, salt restriction becomes a very, very important component. But in any patients which are less than refractory ascites, diuretic responsive ascites, I think we can a little bit of more sodium restriction, which will ensure adequate diet intake also can be thought of. So that is one factor we have to keep in mind. We have to balance that. With no point saying that we should start off with zero salt diet right from
right, exactly. Especially in Indian setup, it is very, very difficult to do that.
Difficult, yeah. If a patient is still diuretic responsive, just one tablet is able to manage well with a tablet or so of diuretic, then you can ask him to
at least cut down by less than 50% what is normal.
Ensure that he gets a proper diet. That's the only thing that matters.
Right, sir.
One more query I have for you as far as the Akin criteria for HRS are concerned. See, once all the 0.3 and 50% elevation of baseline and all is fine in terms of ECIN 1. But we know that ECIN 1 is not necessarily, it is reversible and it's not necessarily requiring any intervention or treatment. So in actual clinical practice, what is the threshold of serum creatinine that you'll take to start terlipressin and albumin? In ECIN 1, you're not going to. If somebody goes up from 0.6 to 0.9, you're not going to start terlipressin and albumin at that stage.
No.
Unless you might stop a diuretic, you might look for other precipitating factors, you might give a volume expander, fine. But what would be the creatinine criteria that you would take in practice to say, I need to start this guy on terlipressin and albumin?
Sir, I think it is the stage 3, sir, stage 2 or stage 3, around beyond 2.5, more than 2 to 3 times.
Yeah.
So once you know that the patient, this is very important, that we know the patient is stable till his last visit. Now we came with creatinine of more than 2 or 2.5. That is where you look for other things and then start him on other things, on the terlipressin albumin infusion.
Actually, I think, sir, we should not base our treatment solely on serum creatinine only, because these gentlemen have very lean muscle mass, and the amount of raise in creatinine does not correlate with the
serum creatinine value. Once again, perfect.
Serum creatinine value. We have to look holistically. The urine output levels, the raise in the urea. These all things have to be taken into consideration. Based only on serum creatinine.
No. See, it's not absolute value of serum creatinine. It is also the rise from baseline. So that takes care of most patients who have a low serum creatinine at baseline. But the point I wanted to make was ECIN 1 is more like a risk category. It's not really an intervention and treatment category. It's not something which you're going to treat with terlipressin and albumin just because you have fulfilled criteria for ECIN 1. And I'm saying that because repeatedly it's emphasized, overemphasized, this is ECIN 1, acute kidney injury 1, and it's also something drastic is happening. But really,
I think once the patient you have seen in ECIN 1, if you look at all the precipitating factors, you can stop the diuretics, give him some fluid challenge or an albumin, simple volume replacement, and stop all nephrotoxic drugs. I think they'll all become normal.
Yeah. Only those who progress to ECIN 2.
Exactly, sir. There's a progressive and regressive was there.
Yeah. So once you take, that is elevated of, ECIN 2 is elevation of 2 to 3 times. Okay, so.
Right. But I think even then the first step is to reduce the precipitating factors or all the nephrotoxic diuretic. First thing is stop the diuretics. I think majority will become near normal.
No, that is what I wanted to convey. ECIN 1 is for preventive action. Take 2 things that are, to prevent the patient from deteriorating. But the interventions come only with ECIN 2 and above.
And even in ECIN 2, sir, first we need to stop all those things and see what is happening.
Yes, then only. And it doesn't.
Then only we need to go for the other things.
So, yeah, I think we've had a good discussion from Mr. Atiq Mohammed. Anything should we...
Really, it's a great evening. The way sir has given presentation, Srinivas sir, really hats off. And the way our moderators, Sivaprasad sir and Satyanarayana sir has taken the program for a lot of many technical queries are going in my brain also. I was not able to express, but Sivaprasad sir has expressed it really from top of the holistic view. I think midodrine, because when we see the other side of the coin, how these patients come, especially the RA and the HRS, normally a lot of patients who get clinically diagnosed, as you have said, there's a lot of challenges when the patient comes actually, and how long the patient will be on therapy, and for how long the survival rate will be the patient, how fortunate they'll be to go for transplant, maybe a liver transplant or kidney transplant in that way. And I'm sure like this medicine will be a saving grace for the patient to extend his well-being and to go further actually. A lot of challenges are there, a lot of medical developments are going on here across the world and in hetero also in our R&D. And I think at the right platform, we have launched our midodrine, sir. We have 2.5 milligram tablets. And I'm sure it will be a great booster to the patient's well-being and the patient's liver actually in treating this RA and HRS cases. And really, thank you very, very much. I really thank our moderators, Dr. Sivaprasad sir and Dr. Satyanarayana sir, and the eminent speaker, Dr. Srinivas sir. Despite the weekend, despite the tight schedule, you accepted the invitation and came under one platform. It's really great. I'm really thankful to you. I thank the audience, a lot of audience were glued to screen, and many of the doctors, especially my international doctors who were unable to log in due to the time schedule, because for them it's a 3 to 4 hour schedule. They are requested to send a video to WhatsApp so that they'll go through it. And any queries, anything related, it's like international and national collaboration. They'll be contacting you for suggestions and treating the patients. Thank you very, very much, sir, for being on air today with us. And really, once again, thanks for the hetero side. Have a great evening, sir. Happy weekend.
Thank you, Emma. Thank you, Shubhrashad, sir.
Thank
Have
you.
a great evening. Shiva bhai. Bye-bye.
Thank you. Thank you.
Bye-bye.
Bye-bye.
Okay.
Bye.
Bye.
Good days.
Mr. Ahmed, thank you so much for the opportunity.
Really great. Some of the way you deliberated things, a lot of it's like we have gone through training sessions, we have gone through many medical programs also before the launch of the program, and you made very simpler actually the slides, and even a common man can understand maybe really the way you diagnose a patient. I saw one-to-one during presence there, and I'm pleasant blessed to have you
Thank you so
as a
much.
doctor. Right, it's a good day. Have a great day, sir. Bye.
Thank you. Good night. Bye-bye. Night.
Thank you, Mr. Bharat, and thank you, Srinivas, for being behind the scene. Good day. Have a great day.
Okay, fine.